and so I'll call the committee to order. I would say to members of the committee that a number of people have asked about passing things out. So there are a number of handouts and various things. I'm sure it's obvious who is behind whatever it is that has been handed to you. Initially, I'd like to welcome a former member of this body, Senator Kenny Wayne Jones, who's over here on my far left. Senator Jones, we're happy to have you here. Are you here to testify, Senator Jones? What a disappointment. Well, so Dr. Subar, since Senator Jones is not willing to testify, I guess we're left with you, or if you'd be willing to come talk to us. Dr. Sapporo was at our earlier hearing and was nice enough to agree to come talk to us today. I would just say initially that my hope had been that we would have more meetings over the summer on this issue, but first marijuana struck, and then Delta struck, and then Omicron struck, and then we'd run out of both Greek letters and time. So we're going to do the best we can today. Doctor, just proceed however you think best. And again, I want to thank you for coming because I know you have other things you could have been doing today.
All right. Well, good afternoon, and thank you all for coming. We appreciate the opportunity to present here today. I want to thank Senator Hobb Ryan for the opportunity to testify to the Senate Public Health Committee and to discuss this really important issue. I'm Dr. Italo Subar. I'm the Dean of William Carey University College of Osteopathic Medicine. And I've been at Carey almost 10 years now. And I would also like to acknowledge that today is White Coat Day on the Hill, and I see a lot of my students here. Would you wave for me? Some of my students, some of my faculty. Wonderful, wonderful. And I think when we discuss important issues for Mississippi, particularly issues related to that are going to have long-term impacts, it's good to have these conversations with everybody. So I encourage you after this meeting to take advantage of some of the talent in this room and to continue the conversation. But I'm here today because I want to share a little bit about DOs, physicians in general, physicians training, but oftentimes I'm asked about what is a doctor of osteopathic medicine? And the thing is that a DO is a fully licensed, trained physician who is qualified to specialize in any area of medicine. And they go through the same duration of training as an MD, 4 years. And then they go on to do residency training, board certification, and then they go into independent clinical practice. About 150,000 DOs make up the healthcare workforce in this country. It's about 15%. Most specialize in primary care. And we've got an emphasis in our curriculum on empathy, compassionate care, and team-based clinical care. If you look at that picture to the bottom corner there, you'll see that was Donald Trump's physician, President Trump's physician, who happened to be a DO. And you can see the healthcare team behind him that was helping give care when he came down with COVID. DOs are licensed by the Medical Board of Licensure, which is well constructed to monitor issues such as medical malpractice, professionalism, and substance abuse. But a few facts about William Carey, our university, our College of Osteopathic Medicine. We were established in 2010. At that time, believe it or not, there were only approximately 100 DOs that were practicing in the state at that time. Today, there are over 1,000. When we began with our school, we started with a class size of 100. And most recently, we have begun a process of doubling our class. Our current class size is 180, and we expect to hit 200 next year. Regarding admissions, we've got about 4,000 applicants or so for our 200 positions. That's about a 5% acceptance rate here at our medical school. With regards to education, our students go to school for 4 years, and they garner the DO degree. Afterwards, they go into residency specialty training. Now, it depends on what specialty they go into, and that will determine the length of time they do their they do their residency or fellowship training thereafter. Family medicine might be 3 years, general surgery 5 years, just as a for example. There are a minimum of 4 national board exams a physician is going to take, and we take our exams after our 2nd year of medical school, after our 3rd year, going into our 4th year, after our 1st year of residency, and then at the end of our residency training, we sit for our board examination. I want to make it very clear that, our approach is a little bit different. You all know what an amazing institution UMMC here is and the great academic center that it is. Our approach is slightly different. Our focus is not necessarily on specialty care. Our focus is on primary care. And we believe that our community-based distributive model is part of why we have been successful. So students come to our campus and they spend their first 2 years in Hattiesburg. Then the 3rd year, they'll go out into a Mississippi community. In Mississippi, we have what we describe as 8 different hub sites. And the students will go to those hub sites, and then for the entire year, each month, they'll rotate through a discipline of medicine. And for us, our focus is primary care. So the first disciplines they're going to rotate through are primary care disciplines. For y'all, that would be family medicine, internal medicine, pediatrics, obstetrics, and psychiatry. But then they will go into the other specialties as well and get the training there. The 4th year is comprised of students staying in that Mississippi community for a little bit longer, do a few more rotations, coming back to Hattiesburg, and also doing their residency audition rotations. Of note, I think it's important for us to understand that our education is in person. Our accreditors tell us it has to be in person. Unless there is an extreme circumstance, a mitigating circumstance, only then can this education be online. But typically, for a very short duration, it's temporary, and you do have to get your accreditor permission. As you see, one of the focuses on a DO program or our school, oftentimes I know there is this, when you're looking at medical schools, or you think about it, you think of these like giant auditoriums and a sage on the stage. And, we are all about getting our hands on our patients. We are out there in our first 2 years of medical school. 3 out of the first 5 days, they're going to be doing labs. And that continues on in their first 2 years of medical school. It's the application of the science that's so important to us, the application at the bedside. That's where it comes together. That's how we have this compassionate care and delivery. You can see many of our faculty using things like ultrasound. That's something that's our new stethoscope. And I think that those are things that are so important because medicine is ever evolving. It's dynamic, it's changing. And we have to always be on top of what's going on in terms of continuing medical education. On the right, you see a picture which is very unique to an osteopathic medical school. That's our osteopathic medical manipulation lab. And our faculty, we learn as DOs, we go through the same subjects as our MD brethren, same biomedical sciences, basic sciences, but we spend some extra time in musculoskeletal area where we look at things like how the musculoskeletal system is a window to health. And it's very effective. Again, it just promotes more empathy, more bedside understanding. And it focuses us on a holistic, compassionate approach to our patients. So I always try to say, people think of basic sciences, and in a lot of folks' minds, basic science means, biochemistry, anatomy, these things. Maybe I don't need to, I could just learn it online. I could just learn these things, stream to my house. But we take a very active approach to learning. And for example, anatomy, we do full body dissection all year long, or biochemistry, we do, and with nutrition, we do education and these kinds of diabetic encounters and conversations. I just want to draw that to you because I think just so we understand that the first 2 years are just as dynamic as the 3rd and 4th year, a little bit differently because we're learning fundamentals, but it's still so important to get hands-on. And the most important thing is we've been doing this now for 10 years, and it's very exciting to see some of these results. Now, I come before the Senate and I come to you to say, I can't guarantee any of these things. These facts are what they are, but we're very proud of them. We work very hard to try to get there. We care about our students, our faculty, they work with them, they nurture them. And when they go into that third year, when they're in those Mississippi communities, they become part of the fabric of that community. And it lends them, it gives them a window, that gives them an idea of, boy, wouldn't it be nice to practice here? Wouldn't it be nice to go into primary care and be a part of this patient and this community, be part of this team here in my community? So Carey is ranked top 5 in US News and World Report among all medical schools, MDDO, for placing our graduates into primary care residencies. That's 70%. We're also ranked 2nd among all medical schools for placing our graduates into rural areas. We're 5th in the nation by placing our graduates into underserved areas. And we're top 5. You know, when you see escalating costs in medicine and you see what's going on around us, you know, someone's going to have a responsibility to try to keep those costs down. We take that very seriously. So we have maintained a very reasonable tuition. And with that, we're one of the least expensive private schools in the country among all medical schools. And again, these accolades are not something we woke up one day and said, we have to do this. We're just trying to do right by our patients. We want our mission is to place primary care graduates into Mississippi and to the broader Gulf South. And so as we look at where they're going, as I noted, 70% go into primary care, 25% into family medicine, 25% into internal medicine, 10% into pediatrics, 5% into obstetrics, 5% into psychiatry. We see that there's another 30% that are going into everything else. They go into dermatology, they go into emergency medicine, general surgery, they go into radiology, pathology, a number of these specialties. So you'll see DOs all over the place. But as I said, our focus is primary care. It's what we do. And this graphic that you see here is where our 1,000 DO physicians are practicing. I come back to you again today to say, before 2010, there were 100 DOs practicing in the state of Mississippi. Today, there are over 1,000. And that's attributable to that little medical school down there in Hattiesburg. It's a beacon. When DOs do continuing medical education, when they have to get all their training, they got to get that hands-on training. It's not substitutable. Therefore, having a medical school, being able to do these things is where it's at. And we take primary care very, very seriously. We care about it. We see our graduates all over the map. The maroon color is respective of all what we're seeing, all our DOs, and the darker red, crimson red, is where our DO graduates have already begun to practice. And I promise you, coming back here in the future, I look forward to having this entire map covered. But it's impressive over the first 10 years what we've been able to do. But I come to you again to say, nobody does it by themselves. Nobody. Anybody that comes and says, I did it myself. I could do it all. You know, they're kidding themselves. We have to have humility. We have to recognize that for us to be successful, for our communities to be healthier, we need each other. This picture is demonstrates some of our faculty. Dr. Tanya Creech, our chair of family medicine, working with the nursing department, showing them, going over intubations and working clearly with them. Our medical students by them side by side, learning together. This is what it's about. If you want a healthier Mississippi, we got to be working together. Not against one another, not on different teams, but working together and investing together. I say this with deep humility. Healthcare, and we've learned this with COVID. We've seen it ravage our communities. Healthcare is very complicated, very challenging, not easy. It causes burnout, it's high stress. But that's why it requires teamwork. You know, when we talk about a healthcare team, a high quality healthcare team is all of us in here. It's all of us in here. It's all of our nurse practitioner brothers and sisters, all of our physicians, all of our nurses, physical therapists, you name it. All of us working, and we're committed to the care of our patients. And when you put the team together, the years of experience, the years of education, the years of clinical reasoning, it's just better for the patient. The other thing that's important with regards to a healthcare team is that, you know, when you're a provider and you're working with somebody and you're conversing with somebody about what to refer, what diagnostic test, The first thing we want to say is we take this as a Hippocratic oath. The first thing we want to do is no harm. First, do no harm. And when you got a healthcare team, that guards against that. That's a guardrail against those things. Teamwork allows us to discuss and deliberate challenging patients. Teamwork focuses us on getting our patients referred to the right specialist. Teamwork, and I'm really talking about healthcare teams here, ensures the highest quality of care and lowest cost of care to our patients. As I stand before you today and as I read the bill, I'm asking all of us to just take a step back, to take a deep breath, to pause. Good, high-quality healthcare, better health for our communities requires all of us working together, requires teamwork. And I say to you today, a house of medicine divided cannot stand. Instead of severing ties, why don't we strengthen the relationship between physicians and nurse practitioners? Why don't we do that by increasing accountability, increasing communication? Why don't we do this by looking at ways we can lower your fees and finding ways that things are onerous and challenging, and find ways to do that, and find ways that we can incentivize us all together to work together. By working together, we can put in some quality care metrics, and in those quality care metrics, that could be part of the incentive to improve overall health care. So what I'm really saying to everybody in this room is what we really need is a true collaborative agreement, one that emphasizes teamwork, one that has accountability in it. And I promise you, good health care, better health for our communities will follow. To you, my nurse practitioner brothers and sisters, you've done a tremendous job. This is COVID. We've all been working close together. You're amazing. I'm inspired by you. And I think we all are. I think we all lift each other up. And Mississippi healthcare is at its best when we are working together, when we are on the same team. So let's not find ways to sever ties. Let's find ways to lift each other up. To those who want to make this about access, the evidence is clear. Access to rural underserved communities has not really improved with these kinds of bills. But I do have good news for you. Your answer to access is standing and sitting right over here. Y'all, come on, wave your hand. Show them who you are. These are our Cary graduates. These are the kids that are going into these communities. And I'm proud of them, very proud of them. They're going to be fantastic doctors. And I care about each and every one of them. And they have a commitment to staying and practicing. I'm telling you this, we're not just saying these things. We're investing scholarships. I've got 14 of my Cary medical students going out to the Delta next year, and they're going to spend the entire year in the Delta. And I think that's what this is all about. High quality primary care physicians are what this state needs. Quality healthcare is not improved without teamwork. Healthcare costs only go up without teamwork. Pay parity increases with these kinds of bills. And one other thing, when you break up the team, who's going to monitor each other? You're only creating more of a divide. And I just don't think that's healthy for Mississippi. In conclusion, I feel like this, honestly, is not really a legislative issue. I believe this is a House of Medicine issue. I believe this is an issue that we need to go together and caucus together and figure this out the right way, to redesign this collaborative. And so that's why I'm saying to you today, let's take a pause. Let's take a step back. Let us have an opportunity to dialogue. Let us have an opportunity to look at this. We want to work with each other because when we do, Mississippi is going to benefit. And if we do, that's better healthcare for Mississippi. And that, ladies and gentlemen, is when Mississippi wins. So I'm going to stop there. I want to thank you for the opportunity, and I'm pleased to answer a question or two. I know that there's a lot of folks that have to get up and present, so I want to be respectful of time.
Well, Dr. Subar, one of the things you mentioned in our discussion at the last hearing was the difference in training that advanced practice nurse practitioners have and the training that graduates from William Carey have. Are you in a position to sort of explain the difference?
You're very kind to ask. I can only explain what we do at Carey. I know that there have been conversations, and I'm not an expert on the education of our advanced nurse practitioners. I know they go through a lot of training. I can only say that for us, our focus, when your focus is independent practice, as that is what your competency is, we do that every day. We do that every day at our medical school. And that's why we go through 4 years of medical school training and thereby go on to another 3 years. If I look at my medical students that have made this investment, have invested their time and energy in this, I love them all. But I'm not going to let my second or third year medical student just kind of go off on their own. There are reasons why we have standards with regards to our education. So I'm speaking solely on the medical side and the way we look at education. But and I'll just say, we do a lot, we do in-person education, and I think that's important as well.
Members of the committee? Questions? Anyone? Again, Dr. Subar, we appreciate your being with us. As I say, I know you had other things to do today. It's nice of you to come and talk to us here on the committee. The State Medical Association has several people that they would like to have present to us. Dr. Weiland, I think we start with you and go from there.
Thank you, Chairman Bryan. Thank you for inviting me and my fellow physicians to speak to your committee. I'm Jerry Weiland, president of the Mississippi State Medical Association and a pediatrician in Vicksburg since 1983. I graduated from the University of Mississippi Medical Center in 1980, and I can attest to how much field of medicine has changed in that time. There is a vast knowledge of treatments and procedures that have developed over that time, and the practice of medicine is significantly advanced. I have the utmost respect for the nurses I have worked with for the past 4 decades in the emergency room, the pediatric ward, the nursery, and of course, in my clinic. My clinic nurse of more than 30 years is an LPN. And although LPNs have the lowest training requirements, she is invaluable to my practice. I work alongside a registered nurse who helps me with my clinical practice, but is also responsible for the vaccines in our clinic of 5 providers. That's a lot of shots. We also have a nurse practitioner who has been a huge help, especially seeing well babies. There is always a pediatrician in the office with her, and she frequently consults with us. If she feels a child needs to be admitted to the hospital, the child is evaluated by a pediatrician who writes the admission orders and takes care of the child in the hospital. This is collaboration at its finest. I hope you will allow Mississippians to continue to have the best healthcare possible by supporting a physician-led healthcare team. I would like to introduce our next speaker, Dr. Teresa Camp-Rogers. Dr. Camp-Rogers is an emergency physician and chief quality officer at South Central Regional Medical Center in Laurel. Dr. Camp-Rogers is here today to discuss the critical differences in the education of nurse practitioners when compared to physicians. More important than the differences are what those differences mean for the safety of patients. She will share the results of the Hattiesburg Clinic and how they made an evidence-based decision to continue a strong physician-led model. Thank you.
Thank you. And Dr. Camp-Rogers, we appreciate your coming back, and we appreciate your being here to present to us.
Thank you, Chairman Bryan, for the opportunity to present today. Thank you to the members of the Senate Public Health and Welfare Committee for the chance to advocate as a Mississippi physician for Mississippians as patients. My name is Dr. Teresa Camp-Rogers. I'm a native Mississippian, an emergency medicine physician in Laurel, Mississippi. I also work as a hospital administrator, a chief quality officer at South Central Regional Medical Center, a level 3 trauma center in a rural area of Mississippi. I'm here as a member and volunteer of the Mississippi State Medical Association. In my current role as chief quality officer, I oversee regulatory compliance. My job is to read and interpret standards. My job is to find if we're not meeting a standard and to do what we need to do to meet that standard. And it is that minimum standard that makes sure that all patients have the same quality of medical care. So with this experience, my purpose today is to share with you my observations as a physician, as an educator of medical students and residents. I've also served as a consultant at an NP school on assessing clinical performance. But my aim is to give you a new look at this issue with data that is up to date, relevant, and specific to Mississippi. Most importantly, I will work to look beyond the individuals in this debate, beyond physicians, beyond nurse practitioners, and focus on the patient. There's 2 takeaways. The first takeaway is that there are challenges in nurse practitioners' education that support the continuation of the physician-led team. What you may not know is that among the more than 400 NP schools out there, 20 have a 100% acceptance rate. 49 of these schools have 100% online education for preclinical courses. And that's where diagnostic reasoning, the process of diagnostic reasoning, is taught. This is without evidence that teaching diagnostic reasoning online is effective. And when you closely examine these schools, there's even more disturbing trends. Many do not set up rotations for their students. This is important to ensure that each rotation is a good educational experience. Many don't screen the nurse practitioners and physicians that they shadow on rotation. This is also important to make sure that the preceptors will be good educators. It's not required to assess students after each rotation to make sure they learned anything. These online schools with 100% acceptance rates prey on nurses who want to further their education and provide a better life for their families. It's important for you as legislators to know about these problems because these factors directly and negatively affect the quality of training. This issue is not with our brick and mortar schools in our state. I do not know how many NPs in Mississippi have chosen online out-of-state schools. Walden University is an example of one of these schools, and they were investigated by the Department of Justice and the Department of Education for just these reasons. The SEC filing specifically describes, quote, potentially false representations to the Commission on Collegiate Nursing Education and false advertising to students about the availability of clinical placement for mandatory courses, clinical site placements. It's notable that some states are catching on. Walden Online MSN program is not recognized by the Texas State Board of Nursing. Another example of an online nursing school not recognized by some states is Purdue Global Online MSN program. It is not recognized by Tennessee or Louisiana Board of Nursing. Let's look at the educational standards for NP school a little more deeply. The NP educational standards do not support independent practice. You have heard me say that NP school is unstandardized. And what I mean by that is that there are standards and they've been approved by the Department of Education. But when you read them, the problem becomes clear. The language in the standards is very open. And in many places, it states that each NP school can do what they want. For example, in the National Task Force on Quality Nurse Practitioner Education, Criteria 2A admission standard reads, nurse practitioner schools may have unique admission criteria. They need only to show that they have had input from faculty. And it is this standard and the way it is written that allows NP schools to admit people without a nursing degree. These are known as direct entry MSN programs, and there are 43 of them nationwide. We do not have any in our state. So let's review some data we've heard before. Physicians go to med school for a long time, we go to residency for a long time, and we take a lot of tests. We do this. We do this because diagnostic accuracy depends on a sufficient breadth of knowledge and a mastery of the reasoning process. This is how we guarantee patient safety. But let's talk about hours. And I think everybody in this room likes to compare hours between nurse practitioners and physicians. But let's ask a better question than hours comparisons. What's inside those hours? What are those hours composed of? I can tell you what happens during these hours as an educator of medical students and residents. Clinical hours in medical school are about 5,000. Clinical hours in residency at the minimum are about 11,000. But each rotation is full-time. We max out at 80 hours a week. At 80 hours a week, we're told to go home. And during each rotation, we are required to write notes. We are required to present patients. We're required to have our presentations critiqued in front of our peers. We get graded on their depth of knowledge and on our presentations and our understanding of medicine. For 8 of these rotations, there's a national board exam. Our core rotations, we have a board exam after the end of those. It's called a shelf exam. And we have to take an exam after each rotation to ensure that meaningful knowledge translation occurred. We have to prove that we can practice medicine safely before we're unleashed on the public. Requiring an assessment at the end of a rotation is a standard for medical schools. And if a medical student doesn't pass one of these assessments, they don't continue. Hours, it is in this way that clinical hours equals competency. So what happens during NP clinical hours? I am not a nurse practitioner. I have not taught at a school, but what I've done is look at evidence from NPs, written by NPs about what happens in those hours. So the total number of formal training hours continues to be 500. Monitored practice hours are 2,000. And the bill we're all here for today to discuss is 6,240. And then they would be able to practice on their own. But where do these numbers come from? How do we know that hours equals competency? The standards for NP training do not require an assessment after each rotation. Not being a nurse practitioner, I decided to do a literature review on the topic of nurse practitioner clinical hours. And what I found was compelling evidence written by nurse practitioners that calls for scrutiny. In 2009, Christine Bray and Karen Olson, nurse practitioner faculty at Texas A&M at Corpus Christi, their nurse practitioner school, they questioned the 500-hour requirement. And after their extensive literature review, the authors concluded there's no scientific data upon which to base the number of required clinical hours. Researchers need to identify what types and how many hours are needed to prepare competent new FNP graduates. In 2012, Donna Hallis and her nurse practitioner team at New York University also questioned the 500-hour requirement. They examined documentation from rotations by NP students at their school. They found that 500 hours did lead to skill acquisition. Learning occurred, but it did not correspond to exposure to all core competencies. Note that they say exposure, not mastery. They go further to recommend comprehensive evaluations and assessments, which, as far as I can read, have not yet been adopted. In 2016, Judy LaFleur at the University of Texas noted that given the variability in learning opportunities at each clinical site, there's no guarantee that each learner will be exposed to the desired clinical experiences. She also used a term called learning by random opportunity. More recent experience from 2021 has to do with pediatric mental health. Dustin McCaig and his team from George Washington studied the amount of pediatric mental health exposure that nurse practitioner students get on their clinical hours. And here is what they found. Nearly 30% of FNP students reported experiencing 2 or fewer pediatric mental health patients during their clinical rotations. Here's what that means. Let's say you decide to get your child evaluated by their nurse practitioner for ADHD. There's a 30% chance that that nurse practitioner saw 2 or less pediatric mental health assessments on their clinical hours. The last and most compelling evidence was published last week. Lavin and a nurse practitioner and her team at Johns Hopkins. Keep in mind, Johns Hopkins is in a state with full practice authority. What they did was they evaluated all nurse practitioner programs that prepare nurse practitioners to work in the emergency department. They examined all state licensure and requirements and scope laws, and they found, quote, extensive variability existing across the academic preparation of NPs working in the ED, as well as in the licensure and certification requirements governing NPs. Here's the most important part. Until this variability is resolved, we conclude that NPs should not perform independent, unsupervised care in the emergency department, regardless of state laws or hospital regulations, in order to protect patient safety. These articles I've described to you today represent scientific data by nurse practitioners and for nurse practitioners that show that the number of hours leading to competency is not evidence-based. This same literature by NPs and for NPs is sounding an alarm that some NPs are not safe to practice alone. With the training of a physician, you can be certain that hours correspond to competency. With comprehensive training, it's our responsibility to lead the team. Where the scope of NP training reaches its limit, it's the physician's role and responsibility to be the backup plan or the safety net. And it should be noted, it's not just a matter of hours, it's the content, the subject matter, and the depth. We agree with our NP colleagues that scope should be commensurate with training. With many of our NP colleagues, we look forward to the increased regulation on NP schools, and we look forward to this increased scrutiny and what it will mean for upholding the NP profession and what it will mean for patient safety. And until that time, it's difficult to advocate for full practice from a safety standpoint alone. The second take-home point I would like you to remember has to do with quality and cost of care. It's critical to consider these two factors. It's essential to look at data for our state. We should look at quality care comparisons for our population because we are, in general, sicker and more vulnerable than the rest of the United States. We should look at cost of care for the same reasons, and it's a lot more complicated than who costs less to hire. Last fall, I had the opportunity to meet with the physician leaders at Hattiesburg Clinic, and they've since published their results. I think you have a copy of the published results from that report. They shared with me their experience and claims level data that unequivocally supports the physician-led team. Hattiesburg Clinic's the largest physician-owned multi-specialty clinic in Mississippi. It's located in 19 counties, and they serve a market of 750,000 Mississippians. It's 25% of the population. And about 3 years ago, in line with continuous improvement, Hattiesburg Clinic sought to determine if their model of providing care met quality outcomes and was cost efficient. And at that time, their model of care was the following. There were NPs that had their own patients. There were NPs that shared patients with physicians. And then there were physicians that had their own patients. There's 3 groups. And the expectation was that quality and cost of care was the same among all 3 groups. And as a business, we can imagine that their goal was to show quality was equal and cost of care was less. And they for NPs, and they anticipated following a strategy in many clinics around the US, hire more NPs and save money. Using claims level data, Hattiesburg Clinic decided to compare quality and cost of care. They looked at 10 years of data with over 300 physicians, 150 nurse practitioners. And what they found was unexpected. Quality metrics for NPs who saw patients alone did not match quality metrics for NPs who saw patients with physicians. It did not match the quality of metrics for physicians, and their data is in that article that you have a copy of. So when you look at quality outcomes, the data from Hattiesburg Clinic showed that nurse practitioners who saw patients alone had lower rates of flu vaccination, pneumonia vaccination, and breast and colon cancer screening. They also had lower rates of patients with adequate management of cholesterol, A1C for diabetes, and diabetic foot and eye exam. They also saw that number of ER visits was higher for nurse practitioners, and specialty referrals were higher. Most remarkable was cost of care data. They found that spending was $43 higher per member per month, and what that translated to was about $10.3 million every year. And when they risk adjusted for patient complexity, that number jumped to $119 million per year. The evidence was enough for Hattiesburg Clinic to completely change their model of practice. Today, all patients are seen by physicians and NPs they share. It's a patient will see an NP one visit and then a physician for the next visit. It's called alternating visits. This decreases cost of care directly by cutting the total number of physician visits in half, but it also ensures quality review of every chart. The goal is to decrease the number of specialty referrals, decrease unnecessary testing, and decrease ER visits. And this innovative approach is exciting and a remarkable solution. And it's based on clear, up-to-date claims level data that at least in Mississippi, cost of care is more for NPs that function independently. What's particularly exciting about this data is it doesn't promote the physician individually, it promotes the team. Together, the physician and nurse practitioner are synergistic in the overall practice model for healthcare in Mississippi. So my goal was to give you the data you need to make the choice to protect Mississippians with a physician-led safety net of care. The two take-home points that are critical to remember are that educational differences support continuing the team, and then the other is the cost effectiveness and quality of care. When that data is examined specifically for Mississippi, the physician-led team provides the best. All of this only scratches the surface. We don't have time or energy to dive into a lot of the other issues, but perhaps we'll get into them after the presentations today. But just because 24 other states have done it doesn't make it right for Mississippi. Mississippi has a unique set of circumstances that require you to consider how each law will affect Mississippians, and this has always been true for the health of our population. This law, if changed, will affect the most vulnerable, where a safety net for our patients is most needed. One of my favorite sayings in my current role, because it applies to life, is that change equals risk. And I encourage you to consider the risk to patients if this law is changed. The system is not perfect, but it isn't broken, and there are meaningful solutions that are possible. Thank you for the opportunity to present today. My hope was to give you objective evidence. The best plan is to continue with a physician-led team. I hope you're starting to get an idea of why I'm concerned, and I hope you're thinking about your voters and how they're going to get the physician-led, team-based care that they deserve.
Thank you. Are there questions from members of the committee? Senator Blackwell.
Thank you, Mr. Chairman. Dr. Camp-Rogers, thank you for coming in and presenting to us again. Just have a couple of questions. The APRNs that work with you guys, about how many hours do they have?
At South Central?
Yes, ma'am.
Hours in school, monitor practice?
I guess
or
transition hours after they've completed their training, and are they new? Or these folks?
I don't have that number, but I can find it for you and bring it.
Okay, so that could help explain somebody's lack of experience or lack of knowledge. If these are fresh out of school APRNs, one, I guess, could assume their knowledge base is going to be a little less than somebody who's been practicing for 5 years. that
I
right?
definitely understand the novice to expert trajectory and,
Right.
and being there myself.
Do physicians make mistakes? Do they misdiagnose?
Yes.
They do, all right. And we have about 24 other states, as you mentioned. Have there been any significant, malpractice cases or cases of harm against patients?
There are actually in the book that you have, Patients at Risk highlights some of the most egregious.
All right, thank you, ma'am.
Thank you.
Thank you, Mr. Chairman.
Anyone else? If not, thank you, Dr. Camp Rogers. We appreciate your coming back again to refresh the presentation you made previously and provide us additional information. It's been helpful to the committee. Dr. Pannell.
Thank you, Chairman Bryan and members of the committee for having me today. My name is Catherine Pannell. I'm the chair of the board of the Mississippi State Medical Association. I'm also medical director for Right Track Medical Group. The team approach to patient care works, and it works well. Right Track Medical Group is a physician-led company. I cannot physically see every patient. I have 2 nurse practitioners that I collaborate with to provide timely care to my patients. We are a great team and we enjoy working together. I review the initial assessments and plans on every patient seen by my nurse practitioners. I then give feedback where appropriate. I am always available via the phone. I'm also physically in the clinic with them on certain days so they can ask me questions while I'm there and we can provide real-time care for patients. If at any time they're uncomfortable with the patient, I'm happy to get them on my schedule. If patients prefer to see a physician, I get them on my schedule as well. We work together, we work well together and speak about patients almost daily. I spend about a half day per week just reviewing nurse practitioners' charts. The patients enjoy our collaborative approach as well because they know that a physician is following their care. I've had my nurse practitioners come to me during one of their appointments to ask advice about patients. Patients feel comfortable knowing that they have discussed their case with a physician. Physicians want the best for patients, and that's through the collaborative team approach. I want to emphasize again that we value nurse practitioners and we want to work with them. We have been listening to their concerns and we have begun to address them so that they can have the best experience being part of the team, but more importantly, we can continue to give the best quality care to Mississippians. It's important to note that there are only around 4% of nurse practitioners that are actually practicing in a setting that would require them to find their own supervising physician. Mississippi nurse practitioners have argued that collaborating physicians are difficult to locate, and when they are able to be located, the cost of collaboration is overwhelmingly expensive. I've never seen concrete evidence of this, but regardless, physicians heard these concerns and responded in several ways. First, the Board of Medical Licensure relaxed any requirements for mileage for collaboration in primary care specialties of family medicine, obstetrics and gynecology, internal medicine, and pediatrics. Therefore, as long as you have an electronic health record that allows you to review the records and a Mississippi license, the physician can be located anywhere in the state. But nurse practitioners still express difficulty with the collaborative process. Therefore, the leadership of this body asked us to find a solution to these concerns. In response to that charge, on November 10th, 2021, MSMA and collaborating docs launched Collab Mississippi. Collab MS is a program that matches nurse practitioners and physician's assistants with the supervising physician. They guarantee a match within 30 days, but most occur within the week. The contract term is 1 year, but with a 30-day out, just in case that partnership is not working out. The agreement also includes malpractice insurance coverage for the collaborative relationship, so separate malpractice coverage is not even required. With Collab MS, the estimated fee schedule is based on fair market rates. To date, Collab MS has received inquiries from nurse practitioners for collaboration in such areas as general practice, wound care, home health, and IV hydration vitamin therapy. Collaborating docs tells us the quotes generated for collaboration within these areas are in the range of $700 to $900 per month, so it is affordable. Since the launch, MSMA has published information about Collab MS to our membership as well as to the nurse practitioner schools at Alcorn State, University of Southern Mississippi, Delta State University, Mississippi University for Women, and UMMC. We have had ongoing conversations with the leadership of the Board of Nursing regarding marketing Collab MS to their nurse practitioners that it regulates, and look forward to moving that collaboration forward in the future. Collab MS allows us to maintain and improve access to care while maintaining and not compromising the standard of care for all Mississippians. Every Mississippian deserves the best and highest quality of health care. No Mississippian should expect anything less. Your wife, husband, children, grandchildren should only receive the highest and safest level of patient care possible, nothing less. The safest and highest level of patient care is through the physician-led team model. Collaboration is proven, it works, and according to a recent survey conducted by MSMA, 98% of Mississippians believe collaboration is best to ensure that Mississippi patients get the care that they need and deserve. Collaboration does not hinder the care the nurse practitioners can give, it simply enhances it. Thank you.
Thank you. Are there questions from the committee? Senator Blackwell.
Hello, Dr. Pannell. Welcome back.
Thank you.
Dr. Weiland also made a statement about she has a collaborative relationship with her nurse practitioners. How much do they pay you?
They don't.
They don't. Are you?
They're employed with my company.
And Dr. Weiland saying they don't pay her. So it's the independent nurse practitioners that are the ones that having to pay. Is that right?
Right. And that's about 4% of all nurse practitioners.
All right. Thank you, ma'am.
Thank you. I had asked to get some information printed for the committee showing the location of nurses and doctors and the schools they attended. And we've only just now been able to get it from printing, which is my fault. I didn't realize it would take so long, but this is as good a time as any to hand this out. This is just information that I had obtained about where doctors and nurses went to school and where doctors and nurses are located in Mississippi. At this point, the Association of Nurse Practitioners has some presentations. Ms. Glasgow, if you're ready, just come on up and make yourself at home.
Thank you. Like,
Oh, I'm sorry. They're right. I can't read. We have Meredith Boston, who is a nurse. I apologize. I'm old and senile, and it's really not getting any better with age. Thank you. Please go ahead.
Thank you. Good afternoon, and thank you for providing the opportunity to testify today. My name is Meredith Boston, and I am a nurse practitioner. I'm proud to be a nurse practitioner. I work at a multi-specialty clinic here in Jackson, and I work in internal medicine. I have 21 years of nursing experience, with 18 years of that being spent in the ER as a registered nurse. The last 3 of those years has been as a nurse practitioner. Let me tell you that the 18 years of ER nursing was the best preparation for my work as a nurse practitioner. Experience is key. I'm here today to share my experience with you. In my clinic, I work with multiple internal medicine physicians, including my own collaborating physician, whose office is 2 doors down the hall from mine. I do not establish my own patients. My role at this clinic is to see all the urgent care needs and help with overflow of routine care to each of the internal medicine's physicians' patients. I send all of my signed charts, which includes my examinations, plans of care, treatments given, and medications prescribed to their primary physician. Patients rotate between their physician on a routine basis and with me for their care. I also collaborate with these physicians in real time as their offices surround mine. So if I need confirmation that my plan of care is the right one for the patient, or if I simply do not know what to do, I have a physician there to back me up. I regularly say to my physicians, I'm sorry, but this is above my comfort level. What do I do? And I'm not ashamed to say that sometimes because I am not a doctor. I did not go to medical school. The best nurse practitioner knows what they don't know, and they know when to ask for help. Each patient discussion that we have provides a great learning experience for me and for them. It works both ways. My ER background is of great value to their practice a lot. For these reasons, I feel that a team-based care model is the best patient safety in Mississippi. I worry about the nurse practitioner that wants to go into the rural areas and practice alone without the safety net of a collaborating physician. Currently, NPs that have no required numbers of years of bedside nursing experience prior to entering nurse practitioner school. This is already becoming a problem. To remove the physician from the care team entirely, as this bill could possibly allow, would open the door for a very inexperienced nurse to practice alone with absolutely no physician backup. In rural areas, this NP will often be the only healthcare provider they see. Again, experience is key, but does not eliminate the need of an overseeing physician in this patient's care. Throughout my years in the ER, I've always served as a preceptor to students and new nurses, and I'm continuing this in precepting nurse practitioner students. During this time, I have to say I have observed an unsettling trend. Some of the NP students, not all, some of the nurse practitioner students, primarily the RNs with limited experience that immediately went to the NP school after a short time in nursing or worked at a job that provided little to no experience in primary care. These lack the knowledge and experience to identify and treat disease processes. Sometimes they have limited knowledge of medications, yet they will be the ones prescribing these medicines. They have limited knowledge of diagnostics, yet they are the ones that will be ordering the test, which adds to overall cost of healthcare. I have always been told to practice by one rule of thumb. Don't order a test unless you know how to treat the result. To put it simply, in these cases, these NPs don't really understand what it's like to be a nurse yet, let alone provide the higher level of care expected of a nurse practitioner. Now, make sure you understand what I'm saying today. I'm not here to downplay what a nurse practitioner is and what a nurse practitioner brings to the table. We bring a lot to a medical team. There are many really good, capable, brilliant nurse practitioners that provide quality care to patients on a daily basis. We are great extensions of a physician, and there is a mutual respect on the current physician-led teams. We can help with access of care. We can play a major role in caring for and treating patients. However, even the best nurse practitioners should be supported by a physician-led team to ensure the best quality patient outcome. Thank you for your time today and hearing our perspective.
Thank you. Are there questions from members of the committee? Senator Parker.
Thank you for being here. I find your testimony just very interesting to me in the fact that you're kind of testifying kind of for the other side, so to speak. And in sitting in this room for different reasons for 25 years, I'm trying in my mind to recall a time where I've seen or heard that before, and I can't think of one right now. But you say a couple of interesting things here. And the way I understand your mode of practice is you're in a large clinic. You're surrounded by a number of doctors who are around you. And you said that sometimes you just don't know. But when you don't know, you immediately reach out to your MD or DO colleagues to seek the answer for that. If you were not fortunate enough to be in a large metropolitan area, what would you do? You know, if say, for example, you found yourself practicing in the Delta, and you didn't have an MD in your clinic with you, and someone came into the office, what would you do for something that you don't know what to do with?
Thank you. That's a
Just you
great question.
personally.
Yeah. I've never worked in a rural area, so I don't know 100% what I would do, but with, a collaborative physician that can be anywhere in the state lines, I would call my collaborative physician and I would say, hey, here's what's going on with this patient. Do you think this is appropriate care? Should I do something different?
Right.
Would you do something
And I'll go further than that, within the MD community, if someone comes in and, you think they have a tumor, or you think that they have something beyond that, in the MD community, I think they will often, they're going to call their neurology friends, they're going to call their oncology friends, they're going to do that. And you bring up an interesting point, because what we're considering on this, is beyond just the degree and the hours. It's the care in the rural settings, which is most important. And I really enjoyed the presentation from William Carey. I was very excited to hear the DO population and how those trends are. But would you not do exactly what you do now if you found a patient in need of care that you couldn't provide? Whether you had a collaborative agreement or not, would you not just immediately pick up the phone, and as a nurse, you would get them to the care that they need, would you not?
Correct.
And, I guess that's the thing to consider on this here, is that, I think both sides are saying the same thing, and we're talking about hours and different things like that. And so, and the conversations I've had with people on this is that there has to be some kind of line in the middle, or there has to be a middle ground, where, if someone, to Senator Blackwell's point, is fresh out of school, or Lord forbid, they're taking all their classes online. I can't even imagine how you could get any degree in the world online. That's a whole different issue that requires some discussion. But if someone has no clinical experience, I don't think they should be practicing on their own anywhere. But, if you yourself, after all of these years with the MDs, and the experience you have in the type of practice you do, decided to move to the Delta for whatever reason, take care of your parents or somebody, and provide care there in an area that has no one who's serving that area, are there any amount of hours that you think you could have had in your prior training and work with the MD community that you feel would be an acceptable amount for you to practice on your own? Or do you think that no matter however many hours you ever have in your entire lifetime, that as a nurse practitioner, you never feel you would be qualified to practice without collaboration?
Very good thought. So here's what I have for that. It boils back down to the very first point. I did not go to medical school. Do I feel competent in what I do? Yes. Do I feel trained? Yes. Do I feel governed by my body? Yes. Do I feel that I need to practice on my own without a physician? No. I have a lot of knowledge. I'm very confident in my knowledge, but I also need the safety net of a physician's knowledge behind me.
For anything that happens.
Yes.
So I'm gonna give you a personal example. If someone in a community in the Delta suffered a tragic injury and was bleeding profusely and was an hour away from hospital, and you happen to be in that community, and I knew you were in that community, do you think it would be more appropriate for me as a member of the community to try to get the person in distress to you to try to at least establish some care? Or should the nurse practitioner there, or whoever it is, just be bypassed, and should the care be sought elsewhere?
I don't think a nurse practitioner should ever be bypassed. And I also think for any patient that's in any kind of distress, the first level of care is always appropriate. But as far as bypassing a nurse practitioner, no, they are plenty capable of taking care of all patients. A nurse practitioner has great knowledge.
But just not on their own.
They need the backup of a physician.
Okay. I'm very confused, but thank you, Mr. Chairman.
Further questions? Go right ahead. Senator Bryant, you're new on the committee. You're wearing a mask.
I'm sorry.
Senator Barnett.
Thank you, Mr. Chairman, but I will have a question for, and I'm sorry to go back, but to this Weiland, who I would like to direct my question to. Thank you, Ms. Weiland, for coming and sharing your expertise on this matter today. And I ask you this question because it states here that you are the president of the Mississippi Medical Association.
Correct.
Okay, so my question is, Ms. Weiland, is that I have in several attempts tried to reach out to the Medical Association in regards to providing health care to places in Mississippi where we don't have health care, to those people who are in desperate need of some type of health care. And would you agree that we have seen many stories aired on the news and other places about Mississippi being one of the most obese states in the country?
Thank you, Senator. I've had children screaming in my ear for 40 years, so what I heard you asking me is, do we have an ongoing problem with care of our rural residents? Is that what you're asking?
Yes, just a simple yes or no.
You know, this has been a problem for a very long time. We have areas in the center of the state and areas of excellence where you can get a lot of subspecialty care, but state medical has made efforts to try to get physicians into rural areas. The Rural Physician Scholars Program has been a success that we appreciate the legislature helping us with. We know that William Carey is trying to put physicians in rural areas. I think it's an ongoing process and it hasn't stopped. I feel like we do continue to make an effort.
Okay, well, the reason why I asked that is because when I talk to them, you know, there's always a cost. When I talk to the people in the medical community, the answer that I get, we can't do this because of cost. Because of cost. We can't provide care because of cost. We can't do this because of cost. It's always about cost. And so when I hear that, I have come up with 3 P's, and that's prosperity, pain, and poverty. To me, is that if the MDs or the doctors are not in the area where there's prosperity, then the pain for those people who are in poverty is never addressed. And now that we have someone who's trying to help fix this problem, we're here today. So my question is, when does the prosperity take a back seat to helping with the pain and the poverty of those who are in those areas that are unserved, so that we don't have to continue to see these reports that come out that saying that we are the fattest state in the United States? I think one of the reasons why we are there is because people in these communities don't have the access to health care that they desperately need in Mississippi. And I don't think that this is a fight to talk about who's right or who's wrong, whether it's doctors or nurse practitioners. I think this is a fight that we are trying to fix a problem in Mississippi so that everybody can have access to health care.
I agree. I think state medical has continued to make efforts to try to get physicians, healthcare teams into the rural areas. It's difficult. I want to ask to clarify, you were saying the cost, are you saying from hospitals, I understand that the investment to bring a physician.
I'm hearing this when I talk about these things. We can't come because economic reasons. We can't come to that community. We can't service because of economics. But, you know, I live in a small town, Heidelberg, Mississippi. Population right now is probably less than 1,000. And serving as a mayor for 16 years, it was my mission to make sure that those residents, not only in Heidelberg, but around that area, could have some access to health care. Nurse practitioners showed up when I couldn't get doctors to do that. To me, it didn't matter who came. I just wanted the people to have health care available when they needed it.
I agree. We need to continue to help get the underserved areas healthcare. And I still feel as though the nurse practitioners should have the safety net of knowing that they have someone they can work with to be sure that they're not just providing care, but providing good medical care.
But wouldn't you also agree that those people who need medical attention should have a safety net of having medical providers available?
They should have a safety net of access to care. I agree. It is extremely difficult in this state to get folks to go into rural areas. It's something that's an ongoing issue. It's something we address. It's something we hope that between William Carey and the rural physician scholars, we can address that issue. You want these people to have quality health care. It is difficult.
Thank you, Ms. Whelan. Thank you, Mr. Chairman.
Thank you. Thank you. And now, I think, Ms. Glasgow, it is your turn.
Okay. Greetings, Mr. Chairman and Senators. Good to see you all again. Hope you had a nice holiday. I want to thank you for the opportunity to appear again and speak before you. I want to thank our MANP board members that are here supporting us, the Board of Nursing, and then we have our community supporters that will speak later on. One person I want to thank too is my husband. He's not here. He's in a white coat seeing about 80 patients today. He could not leave his patients to come down here and be here beside me and help support me on this issue. The Mississippi Association of Nurse Practitioners have met with you and other legislators all over the state to discuss the length of education, training, collaborative agreements, regulations, and transitional hours. We have given you pertinent facts and evidence-based information concerning healthcare access. And as far as evidence-based information concerning healthcare, as to the quality of care that are given by nurse practitioners. I'm not going to do that again. I gave you a handout and we've talked at numerous times in the community. I'm not going to bore you again because I think you get more valuable time than we should interfere with at this point. The primary issue is that in 2020, the healthcare scorecard by Commonwealth Fund, based on 49 measures, reviewed all 50 states. Mississippi was number 50. Out of the top 10 there are 8 states with full practice authority. We're talking about 50. Mississippi's down here. Top 10, 8 of them have passed legislation for full practice authority. Hence, now then we have 28 states that have passed full practice authority in order to boost their access to care in their states. And what we've been doing seems to be on the wrong pathway as far as I can see. You mentioned in 2010, the DOs, there's an increase of 1,000 in the workforce. The scorecard was done in 2020. So it evidently that those 10 years, 1,000 added has not really affected the scorecard they did. So I'm wondering what's the issue? Is it, more workforce out there, or is it revamping the healthcare system? I think that you all have that job. That is your primary job, that you've got to help decide how we're going to do it and what's the best way to do that. Our current adversities with increased aging population, increased chronic disease, pandemics, increasing aging medical doctors workforce there. Many are over the age of 60, as you mentioned earlier. This is quite a challenge for Mississippi. It's time for a change. The Family Practice News, which is a medical newsletter that comes out, had an article from Mayor Hawkins' president, Tom Florence. And he comments that it's the first time in 28 years the nurse practitioner tops MDs in recruiting. Why he, in quotes, puts a premium on easy access to care and cost containment. The last 14 years, the position was held by family physicians. I want you to know it took me an act of Congress to get that newspaper from my husband. He had it, and he and I had quite a heated discussion about that because he has a stack of papers that you can't take anywhere. And I have that, if you'd like to see, I do have that with me today. But that is something quite astounding, I thought. It's time to put Mississippi first. You have the power to do that with your legislation and increase healthcare provider workforce with nurse practitioners. Our request is very simple. Stop forced government contracts for nurse practitioners. You mentioned we are not, you mentioned about severing ties. We're not severing any ties whatsoever with the medical community. Never have, not even in our vocabulary. We are looking at collaborating on any and every patient that we have with the specialist, with other physicians, with other nurse practitioners. We're not severing anything. This doesn't mean I just go out and do my thing. This means I do not have the contract, but I can collaborate. We can all work as a team. That's how we progress in Mississippi. That's how we have a better healthcare system, is working as a team. You're right. That team approach is by everybody. It's not just one member leading and this member doing this and that member doing that and all of us dividing. That is not what it's about. We learned in nursing years ago, teamwork works in the ER, where I've been most of my life, 40 years in education. That works, and division does not at all. And so safety net, yes, there is a safety net. We always have a safety net. In rural Mississippi, in Marks, Mississippi, at 2 o'clock in the morning, I have a cardiovascular patient coming in, having an MI. I have the phone right there. I do the EKG. I immediately send it to the cardiologist who was in Oxford, Mississippi. He said he's having acute MI. He was my deputy over there. I called AirVac and I had him in there, and I called Baptist Soda, their cardiology team. And in 45 minutes, that man was in the cath lab, saved his life. But yes, I collaborated all along the line and saved his life, and he's living today. So yes, we do have a safety net. And those are just a few things you all brought up that I wanted to touch base with you. We want to move Mississippi to the top of that scorecard. And I think there are a lot of avenues to do that. I don't think this is just one. I think there are many avenues that you need to look at. And you men and women in the legislatures and senators, y'all have the opportunity to do that for Mississippi, and I appreciate it.
Thank you. Are there questions? Is not, Senator Horn, is that you?
That's me, Mr. Chairman.
Just use the mask.
Yes, Dr. Glasgow, we heard from Dr. Subar, and he talked about a true collaboration. How do you describe a true collaboration?
True collaboration. I may see my patient and I may call whoever is in need. If I have somebody with heart pain, like I just mentioned to you, I'm going to call the cardiologist. I don't have time to waste to call my collaborative who may be somewhere else doing something else. I call the cardiologist and I work with that cardiologist. And then I also turn around and he gives me direction. I work with the cardiologist who was, once again, another one in the city 45 miles away. So my collaboration was right there. And we did what was necessary to save that man's life. So it's collaborating with everybody, but I don't necessarily pick up the phone and say, hey, I got this down here as far as my collaborative. I don't do that. I mean, if I got an emergency situation, I'm gonna work on it right then.
And,
So it calls a whole team. It's a whole team working together.
and as far as supervision by a specific physician to work under the current collaboration, there's a specific physician that you collaborate with. Is that correct?
I was in the ER. I have worked in several different ERs. In rural Mississippi, you don't have that collaborative right there by your side. Baptist Soda, I was fortunate. I had 7 or 8, and I had all the specialists I could even think of. It was to me, it was a dreamland. I could do anything I wanted to do, test, whatever. We had the availability that in rural areas in Mississippi, we don't have. And so I could work, with them. And if I had something, yes, I could go to them, or we would work together. And a lot of times said, hey, you know what you're doing? You call, and I finally at the point, I knew what I had to do. Just go call the cardiologist, or just go call the OB, or just go call whoever. They had enough trust in me because I had worked with them, and they knew my education. They knew my skills. They knew how I'd been trained. They knew all my certifications and in trauma and everything else. So a lot of times I didn't have to do that because we already had established a rapport and worked together doing that and saving lives.
Thank you, Dr. Glasgow. Thank you, Mr. Chairman.
Thank you, and thank you for
Thank
coming
you.
to speak with us. Dr. Johnson, I see that you're next. Thank you for coming back. We appreciate everything.
Good afternoon, Mr. Chairman and members of the Public Health and Welfare Senate Committee. We came before you in November of 2021 to present the information that you had requested from the Board of Nursing. The Board of Nursing is the largest regulatory agency in the state of Mississippi, where we are responsible for the monitoring and practice of over 70,000 licenses in the state of Mississippi. So we come back today to just say that we are regulatory, and the Board of Nursing is expertly regulating the practice of APRNs in this state, as well as all other RNs and practical nurses in the state of Mississippi. We will continue to do so under this bill. We've researched and looked at the best practices in those states that have granted full practice authority, and the Board of Nursing has rules, regulations, and means to enforce the measures in our Nurse Practice Act to continue to do so. I will preface one thing that I heard today that I do need to clarify. While pre-clinical hours can happen online in any profession, clinical hours must occur in person for nurses. And with that, unless you have additional questions, I defer.
Senator Blackwell.
Thank you, Mr. Chairman. How long has the board been regulating APRNs?
The board has been regulating APRNs when we look back for at least 30 years.
Right. You may not know this, but if you do, how many advanced nurse APRNs have had to be censored or their license suspended or revoked because of malpractice?
I don't have any data specifically about malpractice. However, we do, get information from the National Practitioner Data Bank when that occurs, but I don't have an exact number there for you on that.
Would that be a number you could get for us?
I'm sorry?
Would that be a number you could get for us at a later date?
Oh, sure. I'm sure we can get that information for you.
Right. Thank you, ma'am.
Are there other questions? If not, thank you, Dr. Johnson. Just to be sure I understand the question that Senator Blackwell is asking. He wants to know, as I understand it, the number of nurse practitioners who have been disciplined over the years And any information you have about malpractice. I guess those are two different questions because you can be disciplined without malpractice and get malpractice without discipline. But any records that you have about that over whatever reasonable time, you can find them. I think that would be helpful. Thank you, Senator Boston.
We'll look into that to see if we can get you that information. Any disciplinary actions we take are public knowledge anyway, and that information, that type of information would be available for us to probably get you some numbers.
Thank you. And I'm sorry, Senator Black.
Mr. Chairman, I'd like to ask Dr. Weiland, could you also provide that same information on physicians that have been disciplined or lost their license or suspension for malpractice issues? Yeah, yes, ma'am. Thank you. I'm sorry. I thought you were the contact. Sure.
Just so, I mean, to have some sort of date, what would you say if we ask from January 1st, 2010 coming forward? Is that?
That's fine.
Just so
I
it
just-
won't be, I think it'll be a long enough period of time. It won't be burdensome.
My question would be, are you asking the nursing licensure board if there's been specific malpractice cases against nurses? Is that what you're?
We're asking.
Yes, ma'am.
We're asking the Board of Nursing, do they have information about regulatory action they have taken against nurses since January 1st, 2010? We're asking the Board of Medical Licensure if they have information about disciplinary action taken against doctors since January 1st, 2010.
Ms. Kent, may I
And-
make one clarification though? When you start talking about malpractice cases,
If
in a collaborative setting, the physician would be the responsible.
Excuse me.
Sorry.
And I think the other question we're asking is whatever information about malpractice the licensing agencies have. I don't know whether the licensing agencies do or do not collect malpractice information, but whatever you have, we're asking that. But you were saying about.
I'm sorry, I was just trying to clarify, when you start
yes, ma'am,
talking
go ahead.
about cases against nurse practitioners in this state, they are required to have a collaborative agreement, which means that the nurse practitioner would not necessarily be the person that would have the malpractice claim against them. So I don't know how those numbers would look, but we'd be happy to get you the information on the medical side.
Again, the question we're asking is just whatever information the licensing agencies.
Thank you.
Thank you. We appreciate it. Melinda Bertucci with the American Association of Retired People. Is that right? Or
We're just AARP, just AARP now.
Okay.
Because we represent 50 plus. But thank you, Chairman Brown, for having me here today and members of the committee. My name is Melinda Bertucci. I'm the Advocacy Director for AARP Mississippi. And as you're aware, AARP Mississippi is a nonprofit, nonpartisan membership organization representing 285,000 members in Mississippi. We are a nationwide organization that helps empower people to choose how they live as they age and fight for issues that matter most to families, such as access to healthcare. Reliable access to quality healthcare is a top priority for AARP members. We believe consumers should be able to get the healthcare that they need from qualified healthcare professionals of their choice when and where they want it. And that is why AARP is here today, to express our support for full practice authority. Patients and family caregivers want choices, and they should be able to choose direct access to an APRN if that's what they want. Delays in care make it harder for older residents and people with physical disabilities to age in place. People in Mississippi want to live independently as they age, and they need access to routine care in a variety of settings so they can remain at home. There are roughly 470,000 family caregivers in the state of Mississippi, and they need and deserve access to quality health care in their community, because at the end of the day, red tape doesn't heal, nurses do.
thank you. Are there any questions? If not, thank you very much for coming.
And our colleagues at Amazon were not able to make it, so it will just move right to Russ Latino.
Okay, so the colleagues of AARP at Amazon were not able to make it. Mr. Latino with Empower.
Thank you, Mr. Chairman. Thank you to the members of the committee. We certainly appreciate the opportunity to address the committee on what we think is an important issue. I am not a physician. I am not a nurse practitioner. I would defer to those folks if I was in need of medical care. What I am is a guy that has been working at and running think tanks for a long time. And as part of that, I get to evaluate policy. I get to evaluate the impact of policy, the data that supports policy, and the evidence that supports policy. I would say because I'm not a nurse practitioner or a physician, I have a unique perspective. I don't view this as a physician versus nurse practitioner question. I have no particular affinity for nurse practitioners, though all these lovely people seem great. I have no discord towards physicians because I know the valuable role that they serve in the community. Ultimately, the question for the people on this committee as a matter of public policy is, what are the things that we can do as a state that yields the best results for our citizens? How do we make sure that the people who are in Mississippi who need medical care have access to quality medical care at a price they can afford? And that is the question. That is the only question through which questions about healthcare and policy should be seen and centered through. There are a couple of assumptions that I've heard in the course of the conversation today that I think are worth addressing. I think there was an assumption that someone in support of full practice authority wants to be separated from the team, that they want to operate in a way where they are not taking into account the value created by other members of the medical community. I don't think that's at all true from the conversations that I've had, both with physicians and nurse practitioners. I think both of them recognize the value that each creates. I think both recognize that in the ecosystem of healthcare, they serve an essential role. But it is important to recognize that teamwork generally does not involve contracts of adhesion mandated by law. And I think that's really what we're talking about today. The second assumption was that this is a discussion about whether or not nurse practitioners' training is sufficient. This seems like an odd question since nurse practitioners are already providing independent health care and primary care across the state of Mississippi. Indeed, many of your constituents go to clinics that are run by independent nurse practitioners to get their health care, particularly in rural or impoverished communities. Many of you have been into clinics and received good quality health care from nurse practitioners without having a physician present, without having a physician collaborate on the treatment or the regimen that was provided to you. What we are talking about under the law is whether or not a nurse practitioner should be forced to enter a contract that requires that 10% of their charts be reviewed after they have seen patients. Some cases, weeks after they have seen patients. And that's not reflective of how all physicians operate in a collaborative agreement, but that is what the law requires, and that is what we are talking about. Let me mention briefly, though, on the idea of whether or not nurse practitioners have sufficient training. Never mind the fact that we have this body of experience that they're already providing medical care all over the place. But the average nurse practitioner spends 8.5 years as a nurse before they seek certification as a nurse practitioner. Now, I was trying to do the math a moment ago because we were talking about hours in a pretty deep way. And what I came up with, if you did 8 hours a day, 5 days a week for over the course of a year, in 8.5 years, is about 18,000 hours of real life experience. And then you go and get a degree and you sit for national board certifications. And then under the bill that Senator Blackwell has drafted, you have the highest number of experience clinical hours that are required before you can operate independently without a collaborative agreement in the entire country of the United States. So there's plenty of hours of real training behind what nurse practitioners are doing. There have been some questions about malpractice, and I think those questions are interesting because they're ultimately about safety. Are patients going to be safe or not? Again, I'd argue that there's already evidence to suggest that nurse practitioners are safely providing care across the state of Mississippi. But it's notable that the data actually shows that malpractice occurs and malpractice claims occur at the high end of the training scale when it comes to medicine. This is not a surprise because what we're talking about are people that operate on spines and brains. And when they mess up, they really mess up. It's a question of the complexity and sophistication of the treatment that is being provided. One important thing to note is that what we're talking about here is a model that nurse practitioners have. That model includes recognizing what they don't know and referring patients when they realize that they're operating beyond their means. It works in nearly half the states across the country. The third assumption that I've heard is that this is a discussion about choosing between a doctor and a nurse practitioner. By the year 2030, the National Institute of Health estimates that we will have 100,000 doctor deficit in the United States of America. Medical schools simply are not producing enough doctors. I'm heartened to see the number of medical school students that are here today. There are healthcare deserts that are being created. And if the United States is in the process of becoming a healthcare desert, then Mississippi is the Sahara. We have the worst physician access in the country. The National Institute for Health says that we're going to need another 3,700 physicians by the year 2030. We've got about 5,700 now. Unfortunately, 1/3 of those are over the age of 60, which means they're close to retirement. And unfortunately, 50% of those are concentrated in the 4 major metropolitan areas in the state of Mississippi. So there needs to be a solution that recognizes that oftentimes what we're talking about is not the difference between seeing a physician or seeing a nurse practitioner. Oftentimes what we're seeing is the difference between seeing a nurse practitioner and seeing no one at all. The data from the 25 states, I've heard different numbers depending on how you look at the law. Some say 28, 24, 25, over half the states in the country. The data shows patient satisfaction at or above the satisfaction delivered by primary care physicians. So people like their nurse practitioners. The data shows that costs come down. The data shows in states like Arizona that have done this, that there actually is an increase in nurse practitioners serving in communities that are rural. So there is substantial data done by the National Institute for Health, studies done by Duke University, Brandeis University, all of these things that I'm happy to provide you guys, that show that what we're talking about in those states is an increased access to care, a reduction in the cost of care, and that more people are actually seeking care, which in a state with chronic conditions is probably as important as anything else. The ability to actually have someone that knows something about medicine to have a conversation with you. So I would close just simply with a story. And it's a story about somebody that you all will be familiar with. Former Representative Ron McNeil went into his nurse practitioner's clinic a couple of years ago, and she asked him a question that saved his life, or at least that's how he puts it. She asked him the question, "Do you know that you are yellow?" And the answer was no, that he didn't know that he was yellow, but he knew he was in a serious jam and was experiencing liver and kidney failure. And his nurse practitioner exercised the model. She knew she couldn't treat that. She exercised the model and got him to care that ultimately saved his life. So as we have this conversation, it's important not to be distracted by things that are not actually in controversy. The only thing really in controversy is whether we believe that having an agreement that requires that 10% of your charts be reviewed weeks after you provide care is so important that we're willing to sacrifice all the benefits associated with having more people provide care in the state of Mississippi, a state that has the worst access to care. Thank you.
Mr. Latino, as I understand it, and as someone I think said that my memory sort of all runs together, but my recollection is at the past hearing that someone said, if you go to see a family practice doctor or you go to see an advanced nurse who's specializes in family practice, that what that individual could do for you should be the same. That functionally everything a family practice doctor does, an advanced practice nurse with an emphasis in family practice would do. I assume that to be the case.
I don't think that I'm the person qualified to speak to that in terms of the training and sort of what is in the scope. What I think I am qualified to speak to is the impact of full practice authority in other states, sort of on a macro level. So I would say that one of the other panelists would probably be in a better position to answer that.
Well, obviously, the training that a family practice doctor gets is much greater than the training that a nurse or an advanced practice nurse gets. So if the experience at the clinic is the same, is the problem that we're requiring too much education for family practice doctors?
I think that would be a question for the medical licensure board. I actually think it's a good question. I'm not sure that I'm in a place to say that, the answer to that. What I know is that there are people all over the state of Mississippi that get their primary health care from nurse practitioners who might not otherwise get primary care at all, and as a result of that are in better shape than they otherwise would be.
I think I understood you to say a reference to 24, 25, or 28 states. Is that because there's some states where that are not clearly completely independent practice or not, or we're just having trouble remembering the number?
So my recollection was that
It's okay if you were having trouble remembering.
yeah, my recollection was that it was
happens.
what was 24. Someone else said 25, someone said 28. I think part of that is I've seen different numbers too. I think how people consider full practice authority differs. So someone doing a 50-state survey might look at it and say, oh, well, they still have this little sort of attachment here, so we're not going to consider that a full practice authority state.
Well, it would be interesting to see what the situation is in those states where they're counted differently. I'm assuming there's some thing that exists in those states that would make them counted differently in one survey versus another.
I'm happy to dig into
I don't
that.
know that that's it. Well, actually, since you volunteered, thank you. We accept. If you could find the
I'll do my best.
yeah, Junior, you can do a report for the class on that on Tuesday. But in all seriousness, Mr. Latino, if you could figure out what those states are that are counted differently in different surveys and what the differences is, I think that would help. Are there questions for members of the committee? Senator Johnson.
I heard you say that people across the state of Mississippi are getting great quality care from nurse practitioners.
I think based on the surveys that have been done really across the country, it shows most people are very satisfied with the quality of care that they get from nurse practitioners.
People across Mississippi are getting quality care. And so, and I heard Senator Barnett talk about not being able to get doctors to Heidelberg, but they were able to get nurse practitioners. So what part of the state are we unable to get nurse practitioners in right now?
I don't know that I've got the data in terms of where the distribution is. I know Senator
Not
Bryan.
where they're located. Is there any place that they can't locate?
Is there any place that they cannot locate? No, and that's why I said
So
that.
how do we expand access to care by looking at 10% of charts?
Sure. So there's a economic drag effect associated with the overhead, right? If you are spending $3,000 a year, whatever the number is, on collaboration, that's overhead to a business. The other thing that's presented in terms of risk is that, and this has happened, there are plenty of stories associated with this, where a collaborating physician pulls out or a collaborating physician leaves the practice, and suddenly you're left with someone who literally can't serve their patients.
So are we left with this being the only option, or can we improve the collaboration process to have maybe multiple doctors to ensure that maybe the cost is appropriate for the area? Aren't there other fixes besides just eliminating it?
So I think what I would say, Senator, is that in the states that have eliminated it, we have seen an increase in the number of people who are providing care. We've seen an increase in the number of people who are providing care in rural areas. I think there's still, I mean, if you looked at it and said, all right, what we really want to do is reduce the number to $1,500 for a collaborating physician, that's still an economic drag. It also creates a lot of other risk. For instance, lending, if you're trying to start a business, well, you're trying to start a business based on someone else being there, right? So if you're a lending institution looking at that, that creates a problem. It also creates an incentive for people who candidly are entrepreneurs and want to start a business to come into a state. And so I would turn it on its head and ask, what is the value of a contract of adhesion to the patients in Mississippi? And I would argue that based on the data, there's really not a lot.
I'd like to get that data, and it's similar to asking whether or not doctors are overtrained.
Sure. I'm not going to answer the question whether or not doctors are overtrained. I think they're all trained wonderfully. So thank you.
Senator Horn.
Thank you, Mr. Chairman. Mr. Latino, in the case of a liability question where there's a malpractice issue that comes up, is the collaborating doctor or collaborative agreement doctor subject to malpractice along with the nurse practitioner?
I would defer. I don't know exactly how that dynamic works.
Okay. So if we have an area where there's a shortage of lawyers, if we have an area where there's a shortage of dentists,
sure.
Should a paralegal be able to offer legal advice the same way that an attorney can, or that a dental hygienist be able to offer the same kind of service as a dentist can?
So I think that's an analogy that I hear a lot in this discussion. I would say that respectfully, I think they're very different situations. First of all, there are plenty of attorneys, including attorneys in this room, that tell you that paralegals do in fact practice law. I think the second part of that, though, is sort of a risk question. And we know, because we have nurse practitioners providing independent care, that they're doing a good job. I think the other thing is that we don't have a shortage of lawyers. In fact, if you listen to lawyer jokes, we have more lawyers than we want. So we do have a shortage of physicians. So it's a combination of the need and the risk profile that I think make that analogy one that probably is not great. The other one that I've heard is the idea of allowing a flight attendant to land a plane. And I would say if that analogy were apt to what is actually occurring, then flight attendants are already landing planes, and 10% of the time a pilot walks out on the runway, it tells them they did a pretty good job.
But flight attendants don't get any training at all on being a pilot, but nurse practitioners get training in the medical profession.
Absolutely. And I guess the point I was trying to make is that arguments by analogy often fail if you think about them fairly deeply.
Thank you, Mr. Chairman.
Anyone else? If not, thank you, Mr. Latino. Representative Scoggin wishes to visit with us. Go right ahead.
Thank you, Mr. Chairman. Good afternoon. I know you're tired and ready to get out of here, and I've got just a few brief comments I'd like to make. First, I come to you today not only as a nurse practitioner, but as one of your fellow peers. I have worked as a nurse practitioner for the past 25 years and in the past 6 years in the House of Representatives. I do this every day, and I know firsthand the issues that are affecting nurse practitioners. Will this bill benefit me as a nurse practitioner? No. Number one is I work in a clinic with 2 other nurse practitioners and a physician in a hospital-based clinic. If I work in a hospital-based clinic and the quality assurance officer wants to make that part of our quality assurance that the physician reviews the charts, so be it. But should someone want to start out and go in a clinic and use capitalism and start doing what they want to do, then that ought to be able to do that and not have the contract. You're going to hear a lot today, or you have heard a lot today about collaboration. I'm here to tell you that I collaborate regularly with the physicians and the other providers within our hospital system. I refer not only to cardiology, gastroenterology, and urology. All providers collaborate with other providers, bar none. Recently, the Mississippi Association of Family Practice sent out a letter to their members asking them to contact you, the Senate of Mississippi, and encourage you not to vote for this bill because of some bad issues. Most importantly, that I noticed in this letter was that the bill said it would increase scope of practice. This bill has absolutely nothing to do with scope of practice. So I decided to look up and make sure that I was telling you correctly and see what scope of practice actually meant. And it is the procedures and the actions of a healthcare provider that are permitted to undertake in their practice. We are not asking you as nurse practitioners to do anything tomorrow that we're not already doing today. And I want that to sink in for just a minute. Everything that we do today and everything that we've done in the past is what we're wanting to do tomorrow. Nothing new, nothing's changing, no new scope of practice. All we want to do is practice the way we have been trained in our schooling. Finally, in closing, from the research that I have gathered from AAMC website, there are approximately 900 practicing family practice doctors in the state of Mississippi. 40% of those are over the age of 60. UMMC only accepts 10 doctors into their family practice residency program. As you can see, the bottom line is Mississippi, according to the statistics, is one of the most unhealthy states with high numbers of hypertension, diabetes, and obesity. The bill before you today is one of the most significant pieces of legislation that we're going to pass. This will open the doors for many rural Mississippi communities to have the needed healthcare team that they need and deserve. Thank you for your time. I appreciate each one of you being here today, and I'm open for any questions you might have.
Do any members have questions? Senator Barnett.
Thank you, Mr. Chairman. Thank you, Representative Scoggin, for coming. But my question is, at any time, has the nurse practitioners reached out to the medical association and tried to fix the problem that we're faced with here today? Has that been attempted by either party before we got to this place?
Yes, several times over the past years, and I'm going back probably 5 years, we have met with the State Medical Association. We've met with Dr. Claude Brunson. We've met with Dr. Jennifer Bryan. And at that point in time, we were told absolutely there is no consideration. There is nothing. It's this way or it's no way. Since that time, under some new leadership and some new guidance, they did come up with the new, and I've forgotten the name of it, where the collaborating doctor can be found. What's Collab MS? It's my understanding, and I have no data to back this up, but from the few nurse practitioners that I know of that have used them, they're still paying in excess of $1,000 a month. But that's the only consideration that state medical has given to us as far as a working relationship to try to work something out.
Second question is, the agreement that you all are trying to work out, is an agreement to see who gets to practice, or is it an agreement to see how can we effectively provide health care to the people of Mississippi that can't get health care right now?
What we were trying to work out was the removal of that collaborative agreement that required agreement in order for a nurse practitioner to practice. If I wanted to open up a clinic in rural Mississippi, in Heidelberg, Mississippi, then not only do I have the overhead of the expense and the expenses of the clinic, the nurses, the equipment, everything else, but then I've got to pay a physician anywhere from $1,000, $1,500 to review 10 charts a month. I may or may not see that physician. I, as a nurse practitioner with 29 years experience, am probably not going to call him if you come in my clinic with a broken arm. I'm going to call an orthopedic surgeon and say, hey, I've got this guy here with a broken arm. I need to send him to you. If you come in and I assess you and I think you've got appendicitis, then I'm going to send you for a CT and set you up to see a surgeon. I'm not going to call that family practice collaborating physician and say, hey, this guy's arm's hanging off. What do you want me to do? I would be laughed out of the area. And so because of that, all we want to do is remove that collaborative agreement so that we can remove that overhead expenses to get into the rural communities more often. Thank you.
Senator Parker.
Thank you, Mr. Chairman. Thank you, Representative, for being here.
Thank you.
I'll just a couple of questions. And, after being in practice for 25 years like you've been, when you ran for office, did your frustration over this issue at all influence your desire to want to run and to be here?
No, I hate to say that, but actually my frustration over insurance. I can tell a quick story. I had a girl at Jones College, 18 years old. She was a cheerleader. She was doing a balance act thing and she fell and tore her knee. And I called and wanted to get an MRI and her insurance would not allow it. So I called back, had to do a peer-to-peer conversation with the person. He was a retired OBGYN doctor in Maine. And he discussed with me and asked me all the questions. I told him all the stuff and he refused to do the MRI and the girl's knee is just flopping. All the ligaments are torn. So bottom line is he kept asking me the questions. He said, we're gonna have to do 2 weeks of physical therapy. And I protested, I fussed a little bit. And after quite a bit of argument, he basically said, okay, I'll agree to having the MRI done, but if it's not torn, I'm sending you the bill. Fine with me, not a problem. So we did the MRI the next day. Her leg, all the tendons were torn, ended up sending her to orthopedic surgeon. She had surgery on her knee and she's doing fine right now.
So I guess, in follow-up, that almost sounds like it did kind of lead to that. So, I mean, experience out in practice kind of leads to different things that we do in life. And, I asked this question earlier to Ms. Boston, and I'm going to kind of phrase it and ask it to you too, because I found her answer very, very fascinating on it. You've also been in a large practice where you have access to collaborating physicians right there at the ready all the time and have spent many, many years doing that. Would you, after these many years and hours of experience that you've had, feel comfortable moving to a small town like Heidelberg, opening up a practice and seeing patients there without a collaborative agreement?
Absolutely.
And do you feel that those hours and that experience and that time that you spent has any play in your ability to do that?
Absolutely.
So the thing I've looked at on this, and I think this is what Senator Blackwell has looked at on it, is that, I think at some point there has to be a bar that's set that says to some degree, a level has been achieved, and the purpose of this is to try to figure that out. But in the answers that I got from Ms. Boston, I was frankly very surprised by that. So I assume a number of other nurse practitioners who have served like you for many years in similar practices. Do you know of any of them, just off the top of your mind, who would answer differently to that question?
No, I don't know any of those that would answer differently. I can give you an example. In Jones County, we have 7 nurse practitioner run clinics. Those can be owned by physicians and the nurse practitioner just runs them, or they may very well be clinics that the nurse practitioner owns and she's got a collaborating physician somewhere else, that whatever. And all of those clinics are doing extremely well. I've heard a lot about teamwork, and I think we all are in the same ballgame. We're all in for one team. I feel like that I have a team around me of the referring physicians that I refer to, whether it's urology, gastroenterology, cardiology, whoever, that if I have an issue, just like she said, I'll fax them an EKG, let them look at it. If I'm concerned about something, or if I'm concerned that they're having some issues, then I refer to one of them. But the nurse practitioner run clinics, I feel that all those nurses have over 3 years experience. They've all been there. They're all relatively trusted and feel good with that.
And so to that point, if you did today move to Heidelberg, Mississippi, use that example, your 25 years of experience in doing that, the urologist you would call, would you, by moving to Heidelberg, call a different urologist than you've been using for 25 years? Or would you call the person you've been using for 25 years and collaborating with, on urological needs?
If we're using Heidelberg, I would call the one that I call now, just simply because he's close to Laurel and that's who I use.
And if he were too far away, you would probably call him
If he's
or
too far
her
away,
and
then
say,
I would.
who should I call?
If
In
he's too far
your
away, I
field.
would establish a relationship with whatever community I'm in, go to them, introduce myself and say, hey, I'm here. I'm working this family practice over here. If I've got any issues, do you mind if I call you if I have a gastroenterology question?
And so you're basically saying then that the hurdle at the end of the record checkoff and everything like that is not going to affect your collaborating at all. You're going to continue to collaborate with everyone just like you are, whether you're, if you walk back into your clinic tomorrow, you walk into Heidelberg, you're going to keep doing the same things that you've done, whether this legislation passes or not. You just will not have that administrative burden that would be in place as a result of this legislation, correct?
That is correct. The administrative burden of the contract is the biggest issue.
And at the end of that, do you see any patient that, because that administrative burden was lifted from you, would suffer or be harmed from this legislature, this body making that action, taking that action?
Could be, yes.
So they would be harmed if you were not if the collaborative.
No, I'm sorry. I misunderstood the question.
So let me rephrase that and then restate it then. So by lifting this collaborative agreement and the paperwork, is there any patient that you see right now, if you were putting the example that I mentioned, that you think would be harmed or suffer damage from the passage of the proposed legislation?
On the passage of the proposed legislation with the hours in there the way they are, I think that would be perfectly fine. I don't know of any patient that would be harmed.
Yeah, I thank you. I know you've had a busy day. It's been a busy day for us too, but I think this was a topic that we needed to listen to and talk. And I recognize that not only are you here to speak, but you've been sitting in that chair for 2 hours too. Those chairs are not very comfortable. So I appreciate you being here.
Thank you very much. I don't thank the committee. Thank you, Chairman Ryan.
Thank you. Anything else? Senator DeBar.
Thank you, Mr. Chairman. I can vouch first off that there is no shortage of attorneys in the state of Mississippi. Thank you, Representative Scoggins, for being here. We've been talking about malpractice insurance and so forth. Do you carry malpractice insurance? And if so, are you subject to claims against your insurance carrier?
Yes.
How's that work?
Okay. I'm probably a little bit unique in that the facility that I work for covers me for malpractice, but I also have my own malpractice insurance just for my peace of mind. So I guess I'm double covered, if that's what you want to say. I hate to say that around a lawyer, but
That's good news to me, I guess.
But yes, I do have my own malpractice insurance as well as the hospital insurance.
Okay. And you know where I'm from, and when that chart was put up about the DOs and so forth, I live in one of those counties that doesn't have a DO, and we've tried to get doctors to come there for ever, and we can't get them to come there, and so we rely on nurse practitioners. Mr. Latino talked about Ron McNeil and that nurse practitioner that helped him and saved his life pretty much. Several years ago, she was shut down. Her clinic was shut down because her doctor was backed out or whatever. I don't know what happened, but she was shut down for a week or so. But is that issue been rectified, or could that clinic be shut down today if that same situation where that doctor backed out of that collaboration agreement?
It could, and it does happen either the way the law reads, if the doctor is not available, then you either have to have somebody else or you have to close the clinic. And let's just say, for instance, that doctor, let's say I've only got one collaborating physician and they're not available. They end up getting sick, they get COVID and they're in ICU, then they're not available. And so I would have to close my clinic. Or that doctor, worst case scenario, DEA shows up at their clinic. And this happened in Laurel, that the DEA showed up at a clinic and shut the clinic down. The doctor was not available. They suspended his license or told him he could no longer practice and ended up shutting the clinic down. And so the nurse practitioner could not function.
And so would you agree with me that when you live in a location like I live in, and the people that I represent, where you only have nurse practitioners to rely on, that it would, this independent practice that we're talking about in Senator Blackwell's bill would basically improve access to healthcare for our senior citizens, our poor citizens, those that can't travel 45 minutes to an hour to see a physician, that this is what we need in our rural communities, and that we can debate all the training and this and that, but if it wasn't for the nurse practitioners in these rural communities, a lot of people in situations where I live at would suffer. Would you agree with that?
Absolutely. And I do have some good news for you. There is a nurse practitioner that I believe next Monday is opening up her own clinic in your community. And just simply because there could not be a physician found to go to that area. I don't know how much she's having to pay for a collaborating physician, but I do know that she's opening up her own clinic in that area.
Thank you, Mr. Chairman. Thank you, Representative Scoggins.
Thank you.
Now, Representative Scoggin, as I understood what you were telling this committee earlier, you ran for the legislature because of frustration with an insurance company.
No, sir. That is just one of the reasons. There were many reasons that I ran in the legislature. That just happened to be one of the issues that I did have.
But you were tore up about this insurance company that you thought.
I was ticked off with the insurance company.
And
yes.
so now, as I understand what you're telling us, having that experience with that insurance policy, you're now at a place of work where they've got an insurance policy for you, and you have such confidence in the insurance industry that you've gone out and bought yet another insurance policy.
Yes, sir.
Are there any other questions? If not, thank you for coming.
Thank you.
I want to thank all of you who came and testified. I know that you all had other things to do, could have been other places. All of the testimony was very helpful to the committee. We appreciate your time and we stand adjourned.